So here we are going to discuss the station amyloidosis. What is amyloidosis? Amyloidosis is a condition associated with a number of disorders in which condition which is associated with a number of disorders in which extracellular deposition of fibrillar proteins are responsible for tissue damage and functional compromise. So basically, it is a condition in which there is a deposition of fibrillar proteins in the extracellular tissues, which can be responsible for tissue damage and their functional compromise. These abnormal fibrils are produced by the aggregation of improperly folding proteins. So these are basically the collection of improperly folded proteins. Okay. So what is the pathogenesis of amyloid deposition? So amyloid deposits can occur in a variety of conditions in which in each of which protein composition is different. Although amyloid always has the same morphological appearance, it is biochemically heterogeneous. So how? So production of abnormal amount of proteins. So acquired mutation, if there is acquired mutation, so there will be monoclonal B lymphocyte proliferation, plasma cells, which will produce huge amount of immunoglobulins, light chains. So there will be limited okay, so amyloidosis. Another thing is that intracellular amyloids amyloid proteins are degraded by through proteases and extracellular through macrophages, but in amyloid this process or this mechanism is disturbed. So there is AL protein accumulation. This is about the multiple myeloma. In this case, we have chronic inflammation. So there is a huge amount of production of abnormal proteins. So chronic inflammation, macrophage activation, interleukin 1 and 6 and liver cells, they produce unregulated proteins, SAR proteins, limited proteolysis, and AA protein collection or deposition. The next is production of normal amounts of mutant protein. So here the amount is abnormal, huge amount, and here and so huge amount, so proteolysis will not occur, and so they will accumulate. And here the proteins are produced in like normal amounts, but they are mutant. Production of normal amounts of mutant proteins, so they are mutant. They are faulty proteins. So transthyretin. So inherited mutations which will produce mutant transthyretin, and they will aggregate and they will cause ATTR proteins. So ATTR is involved in amyloidosis of familial amyloidotic neuropathies, several types, and systemic senile amyloidosis, ATTR, and this also I think occurs in hypertrophic cardiomyopathy as well. ATTR, transthyretin, and they occur in familial amyloidotic neuropathies and systemic senile amyloidosis. Okay. Next we have this. Either we have the abnormal amount of proteins, or either we have normal amount of proteins but faulty production. Native folded proteins. So amyloidogenic intermediate misfolded proteins. So monomers assemble to form beta pleated sheath, beta sheet structure and fibril, and this will cause amyloidosis. Accumulation will occur. So this is the pathogenesis. So amyloid deposition or amyloid deposits occur in a variety of conditions in each of which the protein composition is different. So either there is a faulty production or there is abnormal amount of production. So we have this mechanism, and then we have this. These are the different chart. They say that plasma cell proliferation, or in simply, if I say to summarize this, I can say that in this multiple myeloma, we have AL, light chain accumulation, IgG light chains accumulation, and in all the inflammatory condition we have the AA amyloidosis, and sorry, hemodialysis associated amyloidosis, chronic renal failure, we have a beta 2 microglobulins, and then we have the familial Mediterranean fever, uh, familial Mediterranean fever, in which we have the AA as well, and then we have the as we earlier said, that familial amyloidotic neuropathies and systemic senile amyloidosis, we have AATT or transthyretin. Then we have some localized amyloidosis, for example, Alzheimer's disease. We have A beta, um, and then endocrine medullary carcinoma of thyroid. We have in medullary thyroid carcinoma, there is excessive amount of calcitonin production. So we have ACAL. So ACAL means a calcitonin. So islets of Langerhans, type 2 diabetes mellitus, in which we have the islet amyloid peptide. Islet amyloid peptide. So we have AI amyloid proteins PP. So AIAPP proteins are fibril found. Then we have the isolated atrial amyloidosis. So in atrial, you know that they secrete natriuretic peptide, atrial natriuretic peptide factors. So it will be atrial atrial natriuretic peptide fibril. Then we have the investigations. So this is very easy. So biopsy from the affected tissue, most common site is kidney. They can ask this question as well. What is the most common site where amyloidosis occurs? So you can say kidneys. So in case of suspected systemic amyloidosis, gingival and rectal tissue, rectal fat, PET can be taken. So examination of abdominal fat may be taken, and systemic amyloidosis, suspected systemic amyloidosis, staining, Lugol's iodine for gross and histopathology. Okay, so staining are of these types. So we can have Lugol's iodine for gross and histopathology. We can have Congo-red for gross and histopathology, and then we have thioflavin stain, and then we histological stains. Then we have immunohistological stains, and and then we have the amyloid. Okay, so Lugol's iodine for gross and histopathology. Amyloid stains are violet with iodine and sulfuric acid like starch. Amyloid stains violet with iodine and sulfuric acid like starch. Congo red for gross histopathology. It shows green birefringent under polarized microscope or polarized light. Thioflavin stain, and we have immunohistological stain. Then for AL amyloidosis, we can check for, like in multiple myeloma, we can check for Benson protein, serum and urine protein electrophoresis, and immunoelectrophoresis, where we see the M band. Protein electrophoresis and immunoelectrophoresis, bone marrow aspirate, monoclonal plasma cytosis, even in the absence of overt multiple myeloma. Scintigraphy with radiolabeled serum amyloid protein. Serum amyloid protein scintigraphy. So scintigraphy with radiolabeled serum amyloid protein component is a rapid and amyloid component. Serum amyloid P SAP component is a rapid and specific test. SAP bind with amyloid deposits and their presence is revealed. So we have this serum amyloid P protein component. So what it does, that it is scintigraphy, it's radio-labeled chemical, so it emits radiations. So what it will do, that it will bind to amyloid. So where there is amyloid deposition, so it will reveal it. So okay, so this is a bit extra, but we can cover it here. So they say that there is a following neck of femur fractures, Total hip replacement done. Post-op day 1, patient restless, and restless, short of breath, started to desaturate, petechial rash appeared. So this is the typical feature of a fat embolism. What is the cause of fat embolism? Because of the long bone fracture and orthopedic surgery. What are the causes of a fat embolism in general? Long bone fractures, major burns, acute pancreatitis, diabetes mellitus, orthopedic surgery, intramedullary lining, and joint reconstruction. And then we have the cardiopulmonary bypass graft, cardiopulmonary cabbage, cardiopulmonary bypass graft, cabbage. And then we have the how to manage it. So management is totally supportive, preventive to prevent complication. For example, acute renal failure ARDS, give him proper ventilation and oxygen, fluid and electrolyte balance, and general DVT, sepsis, and nutrition. Then we have some specific, but they are totally unprone. For example, ethanol, dextran, and heparin. So they say that heparin they activated the lipases, which will break down the fat particles. So this is totally unproven. And the other thing, they say that dextran improves the microcirculation, which is also unproven. And then they say that ethanol also helps in the process, but it's also unproven. Wait. They say that ethanol was thought to block lipolysis and reduce free fatty acid toxicity, but this is totally unproven up till now. Okay, so we're done with the basically this station was composed of amyloidosis and the giant cell arteritis plus osteoporosis, but I have separated the amyloidosis. So we can, since we have a bit of time, so we can go through a bit definitions of these amyloid related. They're very confusing. So we have, okay, so we have amyloid, define amyloid. So amyloid can be defined as that it is an abnormal protein that gets deposited in tissues in a beta-plated sheet form, making the tissues firm, waxy, and resistant to normal enzyme. Or you can say that they can damage the tissue and compromise their function. So amyloid is an abnormal protein that deposits in tissues in a beta, and the process is called amyloidosis. The process is called amyloidosis. So this is all about the amyloidosis.